I want to welcome you to the 19th Annual Pacific Endodontic Research Foundation Scientific Session. The schedule for today, we're going to hear two presentations, and then we're going to break for lunch. And then in the afternoon, we're going to have some case presentations on herodontics, and we're going to get input from the group, and then Dr. Chi on these individual cases, and hopefully have a very meaningful discussion about how our specialty integrates with sophisticated restorative dentistry. I think it's one of the most important topics within our specialty today. We have a saying in TDO, it isn't about you, it's about who you surround yourself with. And I've had the good fortune in my life to be surrounded for most of my career by the two gentlemen speaking today, and my career has been enriched immeasurably. I'm not going to go through their CVs. You can see them in the booklet. I'd rather talk a little bit about them as individuals. Both of these gentlemen have affected my thinking profoundly in my career and have made me a much, much better clinician. And I know if you have not been exposed to them before from this group, the same will be for you. They will not only, they're not only an inspiration in the clinical sense, they're an inspiration on what it means to be a teacher and a mentor. So without further ado, I'm going to ask Rick to come up. And I think in the early years of your career, you're trying to kind of figure out what your skill set is. You're working on, what the limits are of your skill set. Can you take the dentistry apart without ruining everything? Can you get around the curve? Can you manage the dilaceration? You're in this phase where you're kind of figuring your limits. And then after that 5 or 6 year period, things change and the questions change. They change from not, can I do this case, to should I do this case? And if you think about it, that's what your patient is actually paying you for. They are paying you for not only your expertise and your ability to do the case, but whether you should do the case, if it's in the patient's best interest. And I think with minimally invasive endo, these questions come into very sharp focus because we're thinking now that we can save teeth that we didn't save before, because we're not destroying the teeth by doing the endo. We're doing this minimally, and it makes this question even harder to answer, because now we know we can do it. We can do it minimally. And our thinking is, gosh, we can save a lot of these teeth that maybe before we would have destroyed. So the decision-making process is even harder for us. And the point of this whole day is, what can we learn from a decision-making point of view that can make us better clinicians? And no one's better capable of discussing that than both of our speakers today. So please give a warm welcome to Rick.
Gosh, what a nice introduction. Thanks, Gary. So I've lectured a lot over the years to different restorative groups, prosthodontic groups, and what I call sophisticated restorative dentists around the country, a lot of study clubs. Oftentimes there's implant surgeons in the groups, and I've also participated in maybe 5 debates, quote debates, about endo versus implants. It's usually me and a prosthodontist and a implant surgeon. And usually it turns out to be not much of a debate. We don't usually end up arguing about very much at all. We're mostly in agreement, and probably that's going to be, Winston asked me this morning if he's going to be the enemy here today. I suspect that he and I are probably going to agree on almost everything. It's funny when you lecture to a group of people, they're kind of courteous but kind of standoffish before you lecture, and then afterwards everybody really warms up to you, and they come up to you and they want to talk about things, and they part of it is that you've established, I guess, this common ground, and part of it is probably because there's usually alcohol involved afterwards. But they say things to you that they wouldn't necessarily say publicly, and so I'll talk about some of those things. I've had some really interesting conversations with some of these guys after I've lectured about things. So Gary asked me to talk about kind of my impression of how the thinking is in this so-called sophisticated restorative dentistry community. At least I think that's what he wants me to talk about, and how that's changed over the years. And in any event, that is what I'm going to talk about, whether that's what you had in mind or not. Realistically, though, for those of you that have been on TDO chat, a lot of the things I'm going to say are not going to be new to you. And also, realistically, I'm really just the opening act for Winston here. So we'll get started. I'd be happy to take questions as we go along. I'm just going to kind of give you my thoughts about my impression of things in the restorative community and how things have changed over the last 10 years or so. In the spirit of full disclosure, I always show this slide when I first start out. I don't lecture for any companies, and I'm not here to try to sell anybody anything. So I made up a few things that I consider to be, so-called truths. And I'll just read out over the list here real quickly. As a specialty, we're really much too focused. Go to any endo meeting and you'll see we're just way too focused on the tip of the root and not nearly enough on the rest of the dentition and on the patient in general. And like Gary mentioned, really the question is whether the endo is advisable, not whether we can do it successfully. A lot of times we can do it successfully where it's not advisable. We need to understand better how sophisticated dentists think. And the way you do that is you take courses with them, you belong to study clubs, and you talk to them in a, kind of a non-professional environment about what they think and what they think is important and so forth. When I first started out, so I've been at this now almost 20 years as an endodontist. We did all kinds of crazy, heroic stuff. And a 5-year outcome was considered a good outcome. And now, generally speaking, in the restorative community, I don't think that's true. Since implants have come along, they're much more looking at 20-year outcomes, that sort of thing. And if you pin down, and I've done this a bunch of times, if you sit down with a prosthodontist or a sophisticated restorative dentist and you ask them, so if you place an implant in this patient in the maxillary anterior, how long do you think it's going to last? And they hedge and they say, well, you can't predict that sort of thing. And so I say, yeah, but what do you tell your patients if they ask you? And they say, well, this study said this and this study said that. And I said, so look, I'm your patient. I'm sitting across from you. I'm asking you, you want to place an implant to replace number 10? And I want to know, how long do you think this is going to last? And their answer usually comes down to, they say, well, 20 years. I think maybe it'll last longer than that. Depends on the circumstances, but 20 years is what I'm shooting for. And so that's probably the same thing that we should be shooting for when we consider doing treatment on endodontically treated teeth. I mean, or doing endo on teeth. There's certainly exceptions. We treat a lot of old patients. There's certainly a lot of exceptions, but generally I think that's true. We need to have considerable expertise in restorative dentistry and at least some expertise in implants. The people in the restorative community respect you a lot more if they think that you know a lot about restorative dentistry. In many cases, in many of the dentists out there, probably we should know more than they do, at least when it comes to endodontically treated teeth. And if you can't adapt to these truths, you probably don't have a very good chance of having a fee-for-service practice. So some of the slides I put in here are slides that I've used in these debates and I've used in lectures, and this is one of them. I always show this in the debate. So these are the things I'm not going to talk about, and you can kind of go down the list, and I tell them, if you want to hear about these things, just go attend a regular endo meeting. Pardon me? Yeah, that is scary, isn't it? That is scary. So I posted this case on TDO Chat a few weeks ago, and this, I think, is representative of a big problem we have in endodontics. So this case was posted on Facebook, you know, the AAE website, Facebook. And the person that posted this was one of our residents, actually, one of the graduates from our program in San Antonio. And she wrote this big, long thing about how wonderful regenerative endo is and how bright the future is and all of that. And she got this whole list of people afterwards that said, oh, that's so wonderful, that's so great, you know. I showed this to some of my friends in the restorative community, and their reaction was, like probably most of ours is that, well, okay, so she treated the apical periodontitis successfully, but she basically destroyed the tooth in the process. Actually, a lot of the people that gave her all the accolades afterwards were graduates of our program in San Antonio. So this is a problem we have in endodontics. They're so focused on, okay, the bone healed at the apex, but there's nothing left of this tooth when she was done. So in making the decision about whether to do retreatment or extraction, there's these series of teeth kind of tell three different stories. If you look at the first molar there, that looks like a pretty reasonable one to retreat, because if you look first at the restorative, from a restorative standpoint, it has a decent crown on it. There's a decent amount of coronal tooth structure left. It's probably an untreated distal canal. We can do a cone beam and tell for sure. This is a very, the shapes are small, so we don't have to take a ton of gutta perch out there and make great big shapes. This is a very reasonable one to retreat. The second molar, again, the crown is not quite so great, but the thing has been pretty well hogged out. When they made the access, they gouged it to the mesial. But still, this is, depending on the circumstances, this is maybe a reasonable one to retreat. And then the one on the picture on the right, first of all, from a restorative standpoint, if you prepare this with a traditional crown with a 1.5 millimeter shoulder, there's going to be virtually no coronal tooth structure left. And then if you look closely, I don't know if you can see, there's a broken instrument in one of the canals. You know, maybe we can retreat this successful, but maybe it's also going to need surgery. So really, is this tooth worth retreatment, maybe surgery and a new crown? If it's a decent implant site, maybe that's a better way to go here. This sort of situation makes no sense to a sophisticated restorative dentist, having this one weak tooth in the middle in between a series of implants. And this is actually a slide that Winston gave to me. This is his quote: "Den's been retreated twice, the sinus tract is back, and now the endodontist is considering doing endodontic surgery, root end surgery." So this kind of thinking doesn't make sense to sophisticated restorative dentists. In this case, there's been all kinds of treatment done on all of these teeth, and really the only one that's doing well is the single implant in the middle. And so this patient ended up having the other 3 incisors extracted and implant-supported prostheses. And in the old days, you know, we had all these strategies for dealing with pure abutments, you know, a stress breaker and that sort of thing. But in this day and age, this sort of treatment planning, probably tying a lot of things together, probably doesn't make sense. In this case, the endo was done well, the restorative was all done well, but now we're 5 years out and this premolar is going to need to be extracted. And we do great, the endodontists do great because this money's already been put in the bank and spent, but the patient doesn't do well. And the restorative dentists have to deal with this, have to deal with an unhappy patient. They spent a lot of money on this 5 years ago, and now it all has to be redone. We don't see that so much ourselves. We're kind of fat and happy and out of the picture by that point. Same thing as before here. A lot of treatment would have to go into retreatment, possibly surgery, because again, there's a broken instrument in there. The crown has an open margin. You have to ask yourself, is this tooth worth all of that if there's other good options available? And we get stuff like this referred to us all the time for, not so much anymore, but we used to for retreatment. I mean, that second molar, does anybody want to retreat that? And 19 maybe is a reasonable one to do, but certainly not 18. This is a case from this shows how thinking has changed somewhat in the restorative community. This case is probably 7 or 8 years ago, a while back. Patient was referred to me. So this is a 74-year-old lady. Her whole mouth looked like this. I'm just showing you one quadrant here, but she basically had no decay until recent years, and her mouth is dried up to some extent, and she's on a bunch of medications that tend to make her dry, and her oral hygiene's probably not as good as it used to be. And all of a sudden, she has this big problem with caries. So I evaluated her, and like for this quadrant, all the pulps were vital, and I said endo wouldn't be a problem on any of these teeth. We have a perio issue between the second molar and the first molar. One thing you might consider is extracting the second molar. That would solve that problem. So myself and the periodontist and the restorative dentist and the patient got together and we discussed the different options here. And ultimately, this is what they did for this lady. They extracted all of her teeth and made implant-supported prostheses. And this, when I show this to some audiences, they gasp. But this was the logic behind it. This lady's 74. Yeah, we can restore everything and get her back to normal function, but is she going to be able to maintain it? Probably not very well, and she may be in 5 or 10 years, she may be back in the same situation with caries everywhere. And so their thought was, well, she's 74 and she's pretty healthy. She has pretty good bone available now. All of that stuff is likely to be worse in 5 or 10 years. And so this is ultimately what they did. And this is something that you never saw probably prior to about 10 years ago or so. Yep. Probably so. Yeah, probably so. But maybe not. I guess it just depends. And this is kind of a similar type of case. They sent her for evaluation of, retreatment of number 2, and they said the plan was to take all of the old crown and bridge off and redo it. And so I said, well, if you're going to redo the crowns on the premolars, I said I can probably retreat number 2 successfully. If you're going to redo the crowns on 4 and 5, you might consider having the silver points taken out, and it'll be easier to put posts in and so forth. Anyway, nothing much came of it, and we called to see what had happened, what they had decided to do, and ultimately they extracted all of those and put in an implant-supported prostheses. This is a case, I've posted it a few times over the years on TDO. We've been following this lady. I first treated her in 1999, and she was referred to me from a periodontist, and the plan was for me to do endo, and the periodontist was going to do a distal buccal root amputation and then eventually a crown. So she came in and I did the endo, and she didn't get back to see the periodontist, and I saw her at 6 months and she was almost completely healed. And you can see the last 2 here from last year, they're 16-year recalls. So these kind of patients, for the most part, don't make it into my office anymore. And the few of them that do, we don't treat very many of these anymore. We'll talk about this case a little bit more later. And this is another one. Even some of them like this don't get treated. They end up getting extracted. It depends on the doctor. This one, first of all, when you look at it from a restorative standpoint, it's not very promising. I mean, there's a lot of restorative material and not that much coronal tooth structure. But look at how the restorative dentist restored this eventually. Look at how the crown is. There's not a big shoulder down in the cervical area. It's just a little, you know, the patients always call them caps. Well, this was just like a little cap that they put on the top. Very conservative, especially for metal ceramic. But this was from an endodontic standpoint, this was a reasonable one to retreat. You could not probe into the furcation there, even though there was bone loss there. And again, the shapes were pretty small, so we didn't have to go real big. And so this is doing fine after 11 years. In these kind of cases, absolutely don't get to treat anymore. Pretty severe perio on the first molar. And so we treated both of these, and the distal 18, you can see it healed perfectly. And then 19, there's still a perio problem there, but they've been able to maintain it. It improved after the endodontic treatment, and there's still some pockets and some bone loss, but they've maintained it well for 11 years now. So again, most, especially 19, teeth like this get extracted for the most part. You know, if it's especially if it's a reasonable implant site. We've talked about this a number of times that we rarely get to see our own failures. A few years ago, we did a recall in our practice, kind of like on a much smaller scale than like what Bob Grover's doing. We recalled a series of patients that I treated at least 10 years earlier. I was curious to see how many of them had failed, and then we tracked down some of these patients to find out, you know, how and when it had failed. And this is just one of those cases. Now today, that number 13 probably wouldn't get treated. It probably would get extracted. But anyway, we retreated it, and the restorative doctor put a crown on it. And when we saw this patient, you know, 10 or 11 years later, unbeknownst to us, that tooth was gone, and 14 was also gone. And same deal here. This one has kind of a funny story that goes with it. So we took these two posts out and retreated it and saw the patient at 6 months. The third box that you see, the third radiograph, it was at 6 months. You can see it's been restored, and the radiolucency is healing. So the patient came in on this recall, and he says, oh yeah, doc, I remember when you did that for me. God, it was great, and I've never had a bit of problem with it. So we snapped a radiograph, and there was an implant in there. He forgot that he had it extracted and had an implant put in. So patients are terrible historians, but you know, again, we had no idea what had happened with this patient. And that was true of all of them we recalled. Everyone that we recalled, we had no idea whether it had been successful or had failed. Part of the treatment plan at the time was to retreat 15 also. You can see the radiolucency associated with 15. And it was, I'm not sure how long 14 and 15, how long ago they had been treated, but some years before we treated 13. And so here we are 10 or 11 years later, and 15 still doing fine. So this was a kind of an interesting retrospective study that was published in JOE at the beginning of last year. It was from a public health clinic in Sweden, and it gets quoted quite a bit now in endodontic circles. Anyway, the interesting thing about it, it was a fairly large number of patients that went out at least 10 years, and they got the patients back. And the interesting, so almost 20% of the teeth had been lost along the way. But the interesting part was, of the 68 failures, only 5 of them were endodontic. And that's exactly the same thing that we found in our recall. Our numbers on a smaller scale were almost exactly the same as this study. The only exception was they had more caries than we did. We didn't see very much caries. But it's kind of a recurring theme that we've talked about on chat a few times, is that if you do a decent job on the endo, it's probably going to be successful. The teeth tend to fail related to structural issues down the line. The other thing we found in our recall was that very few of the failures that occurred in the first 5 years. The most common was about at the 8 or 9 year point, something like that. And the most common failure we saw were premolars that snapped off. So the good news for what we do is that teeth are really strong and they last, longer than we think a lot of times. I hear people say, well, this will never last a year, or this will never last 2 years. They almost always exceed our expectations in that regard. And so here's a tooth I retreated, a long time ago. Took a post out and kind of hogged out the coronal part in the process, and yet here we are 12 years later, and it's doing fine. It has a new crown on it, and these are some teeth that I treated as a general dentist around 1990. I think one was in 89 and one was in 91. This is a patient I saw not too long ago. He's starting to have a problem with caries, but all of these teeth are fairly typical of what we see in the long term. Most of them have got crowns on them, a lot of times gold crowns, and there's just a lot of remaining tooth structure. They haven't been gouged out and the canals haven't been over prepared and so forth. A lot of times the endo doesn't look so great. This looks pretty good for that time in my career. This is another case I treated as a general dentist. This is one of my wife's friends. I retreated the molar and did initial treatment on the premolars and did all of the restorative work too. So this endo isn't really up to the standard that most of us try to practice today, but here we are now 32 years later. This is from 1984. The other interesting thing about her is these amalgams on the bottom are 58 years old. They were done in 1958. So good conservative amalgams last a long time. You're not ever going to see a 58-year-old composite. The other thing is that, just to kind of brag a little bit, I waxed up and cast all of these crowns. In fact, I did the porcelain on the premolars. I'm not going to show you that because they're pretty ugly. But these crowns that I did, they fit pretty well, and they've really held up well over the last 32 years. So in some of these private conversations that I've had, with sophisticated restorative dentists, these are some of the things that they've said, and some of this stuff's kind of hard to hear actually, but they say they've had fairly bad experiences with endodontically treated teeth, that they consider them a compromise, and particularly if they're doing a rehab or really complex restorative work, they really consider them a compromise. They don't trust them no matter who did the endo, whether it was an endodontist or somebody else. They really don't trust them. Now this isn't universal, but this is a common theme I've heard from a fair number of different people. Most of the endo that they refer, it's after the fact. It's so they've done a rehabilitation and one of the teeth develops a pulpal problem. Most of them that they refer now are after they've been restored. When they see presentations given by endodontists, they say no consideration is given to the restorative situation. It's all about the root end and the root. And that's totally true. I've been on a bunch of programs with other endodontists where I speak first, and then the guys after me there, and I talk about the importance of the restorative aspect of it. And the guys after me, you can see they're embarrassed because they're showing these cases that have got a terrible restorative prognosis. The endo they did was nice and it healed and everything, but they kind of make reference to, well, I could have restored this, or, well, maybe this wasn't the greatest tooth in the first place. But and they view endodontists as being kind of defensive and tend to make excuses when things don't go well. So when you deal with your restorative dentist, don't be that way. So this is what they really want to avoid is this patient paid $60,000 to have crown and all this expensive crown and bridge done, and after a year the tooth broke off, this lateral incisor snapped off. That's why sometimes they extract what we consider to be healthy teeth that could have been, quote, saved, because they want to avoid this situation. The patients, if they spent $1,500 on a crown and $1,500 on a root canal procedure and things fail, they're unhappy, but they're not nearly as unhappy as if they spent $60,000. And, they thought, I've heard this from patients sometimes, so I had all this expensive treatment done, you know, I had crowns put on all my teeth, and I thought, well, now my problems are over. And they say, well, you know what? Now my problems just began then. That was just the start. It's funny too. So this is John Coy's tooth. Okay, John gave me permission to show this. A few years ago, Roy Caldestat was one of my classmates as a resident, and he's John's endodontist. And John is, I wouldn't say that he's against endo, but he's very conservative. He's very aggressive, I should say, especially in his complex cases in extracting questionable teeth. But this was his tooth, and he knew it was cracked, and he decided to go ahead and have it treated. I think as much as anything just to see how long it would last, and it lasted about a year. This is, some of you may know Bob Cronin. I know Winston knows him. He's the past president of the AARD, and he was the past president of the Prosthodontic Board. And he and I have been friends for many years. We served in the Air Force together, and he was the residency director in San Antonio when I taught at the dental school. And anyway, he kind of half jokingly, half not, you know, said this to me a couple times. Endo should be a 2-week residency, and the second week should be a review. And if you know Bob, that's a typical thing for him to say. Nonetheless, when his wife developed a problem with number 3, she had a crack through the distal marginal ridge and into the distal buccal root. And so I did endo for her, and Brian Mealy, a periodontist in town, did a distal buccal root amp for her. So sometimes they say one thing, but when it comes right down to it, they don't always do the same thing. This is another prosthodontist that practices right near us that hardly ever refers anything to us. They're very aggressive in extracting teeth, and yet this is his wife. When his wife developed a problem with the second molar there, I sent her over, and this was about probably 10 years ago, sent her over and for endo. So when I'm in these debates, one of the things they always ask for is they want you to talk about the success rate of endo. Okay, so our literature says it's somewhere between 30 and 97%, so a pretty wide range. But most of the studies are in this 80 to 95% range. But it's hard to, and initial treatment is higher than retreatment. That's pretty much universal in our literature. But it's hard to define exactly what success is. You know, now we're going more and more towards survival as being success. But it's a very fuzzy definition as to what is success, and also what time frame you're talking about. So does anybody know how many randomized prospective outcome studies there are on endodontic treatment? Yeah, I don't think there's any. There's some prospective studies, but I don't think there's any randomized ones. So for this last debate I did in Dallas in January, I looked in PubMed to see how many prospective studies there were on implants. As of last December, there were 328. So it's pretty hard to argue the literature with them. It really, as we all know, it really comes down to, decision-making comes down to individual cases. So this is, if you look at all of the studies grouped together in the endo literature, about 83% is the average quoted success rate. And it's interesting that it hasn't changed since the 60s. If you look at it 10 years at a time, the studies are all about the same. The average is the same. And this is a slide from Kish. That's where the 83% came from. This is the study, of course, that the endodontists always quote, the Salarabi and Rothstein study with the Washington Delta database. And so I also looked at some of the implant literature. You know, I didn't dig deeply into it, but like this Dirks group in Sweden, they've published quite a lot looking at large numbers of patients who've had implants. And so this particular paper, they did 9-year recalls on all of these patients on, what was it, 2,700 596 patients. And as you can see, the failure rates were low. Overall 7.6% had lost at least one implant. But they found a lot of peri-implantitis and what they call peri-mucositis, which is, I wrote their definition down there, and that was pretty common. This is just another one of the studies that this group published. And then this is a quote from Dennis Tarnow in another of the articles there in the Journal of Dental Research. This idea that they don't last forever, there seems to be more and more of this in the literature, that this idea that, well, you should tell your patients that some of these will need to be revisited over the years. And then I'm sure the endo community will lock onto this article. These are a couple of periodontists, teeth compromised because of periodontal disease or endodontic problems, may have longevity that surpasses that for the average implant, and they quote a couple of other studies. In 2006, they did this joint symposium between the prosthodontists and the endodontists, and they came up with this joint statement, and it said equal survival rates of single-tooth implants and, wait a second here. Yeah, equal survival rates for single-tooth implants or endodontically treated teeth was part of the longer statement. Again, when I talk privately with most restorative dentists, they don't believe that this is true. A couple of the articles that came out of it. And this is kind of interesting. The Washington State Delta database, besides the Solarabi and Rothstein and the Lazarski articles that came out related to endodontics, they did a study that I don't think they ever published. They looked at this large database of patients, and they said if you replace a single tooth with an implant versus a bridge, what is the likelihood that the abutments will need further treatment of some kind? And it was 9 times greater for a bridge than it was for a single implant. So of course implants aren't without their issues, and I've got a whole collection of these. I put a few of these pictures in here. Especially in the anterior. It's like putting in a post wrong, huh? And I just saw this one just recently. That's kind of cool, isn't it? And this is one of Mike Trudeau's here. Isn't that a nice result? So when we make decisions, we all have probably a different list, but this is my list of things. What does the patient want, of course, predominates, but you have to look at the overall treatment plan, the structural integrity of the tooth. Is there a caries problem? Who's doing the restorative is important. And especially the probability of success, if you're going to do endo, the probability of success versus the cost of failure, and will it hinder further treatment? And this is a very common comment that I hear in these study clubs is if I refer a patient to my endodontist, they always quote, get a root canal. So if the patient goes over there, they're coming back with gutta-percha in their tooth. And something's wrong with that. There's this view, I think in the general dental community, and maybe to a lesser extent in the endodontic community, that endodontics is just like this. Root canal therapy is this mechanical procedure, and that very little thought needs to go into it. You just do it, you do this mechanical procedure, and you're done, and it works. It's often viewed as prescription with little or no forethought. So I would argue the opposite, and when I talk to these groups, I try to argue the opposite and show examples that should be treatment planned and performed in the same thoughtful manner as other dental procedures and incorporated into the bigger treatment plan. And then how the endo's performed affects the success and failure of the restorative. How the restorative is performed affects the success and failure of the endodontics. So start with sound teeth. The endo should be done well, you know, whatever that means. I'm less and less sure what that means as time goes on. And preserve as much of the tooth as you can. I mean, that's the bottom line. And ideally, they should be restored immediately. So whenever possible, remove all the existing restorations and caries to assess restorability. And of course, this study that was done a few years ago by Paul Abbott showed that you really can't assess restorability very well unless you remove all the restorations. Whenever possible, all the restorations should be removed. Now, if the crown has caries on it, that's another story. But yeah, generally speaking, no, if it already has a nice crown on it, no, that's not what I'm talking about. Yep.
Do you think endodontists can assess restorability if they don't do the restorative?
Probably not. And they're not asked to, I don't think. I mean, you are? No, I know, but you know about restorative. I'm talking about most endodontists are not in that loop at all. The patient gets referred over and they do the endo, and that's their total involvement in it. Yeah, I'm asked all the time to assess restorability. In fact, I want to do it. I want to take out the restorations and see what's left. And yeah, and I'm sure you're the same. I don't think that's common at all. I can tell you in our city, there's one other endodontist I think that does restorative besides us. Cade Roundy, some of you know him. I don't think anybody else does it in San Antonio, and so I don't think they're involved at all other than putting gutta percha in the tooth. Yeah.
I would point out that the comments from your sophisticated group of restorative dentists suggest that endodontics actually kind of ruin the restorability of procedures.
Yeah, some of them, you know, this whole minimally invasive concept, the restorative dentists get this right away, you know, because I talk about that quite a bit. And the sophisticated restorative dentists, they have no argument, no problem with that whatsoever. It's just the endo community that's resistant to it. They're not resistant to it at all. They think it's great. Yeah.
Rick, how do you address this double standard that exists with many restorative dentists, where they'll do one thing on their patients and then they come into you to be treated personally and it's a different story? I mean, how do you address this?
Okay, yeah, okay. I'll let Winston, because it's not really an issue for me. Most of the people that we work with, we're pretty much in lockstep with them. It wasn't always that way, but over the years, our practice is kind of, there's some exceptions. Rick will tell you there's definitely some exceptions to that. But for the most part, we think, first of all, we think alike pretty much with the people that refer to us, and they respect our opinions about these things and usually go with our opinion, ask our opinion and go with it.
But when you lecture in general,
yeah,
I mean, there definitely is a double standard.
Yeah, there is. Yeah, I'll let Winston talk about that. He's much smarter than me. So this is just when I taught for a long time at the dental school part-time, and one of our residents did this case, and I saw it at the second, at the bite wing view there. So of course I jumped on him about, you know, doing endo through caries. You know, it's just not an acceptable way to operate. So teeth like this, yeah, it's easy to do the endo would be really easy. But long term, you know, what's gonna be better for the patient here? Again, the endo would have been easy here, but certainly an implant or a bridge in this situation was a better choice. And look at this case, this retreatment. So somebody retreated this. There was hardly any coronal tooth structure to start out, and in the process of doing the retreatment, they got rid of all of the rest of it. You know, this just doesn't make any sense. This just doesn't make any sense at all. But this isn't that rare. This is a patient that was referred to me for retreatment of number 3. So yeah, I can retreat that. You know, I can take the post out and there's some metal thermofills. I can probably retreat it successfully, but look at the bite wing view. There's just hardly any coronal tooth structure, and I'm going to remove more of it in the process of retreating it. And again, this was a reasonable implant site, and so we referred it over for the implant. Yeah, sure.
A sophisticated restorative dentist, wouldn't that dentist be able to make a decision looking at these teeth? Why would they need an endodontist to make all of this? Why would they even send a case like this for treatment and look at a
Well, I don't know if
unless they believe that that particular patient can, in that particular patient, that tooth has a chance if the endo can be fixed.
Yeah, first of all, I'm not sure this was sent by a sophisticated. I don't recall. It's been a few years. But usually in a case like this, they might, if they have a question about it, especially if it's not a good implant site, they might send it over just for an opinion. Again, it's just part of the give and take of working with good restorative dentists. Yeah, they wouldn't send it over if they just didn't think there was a chance. Yeah. So this guy sent this patient over. He'd done all of this work on him to, consider, I don't know, retreating some of these teeth. So obviously that's not a good idea. But when you look at the quality of the restorative treatment that was done here the first time around, I mean, it's not going to be any better the second time around. Certainly this patient is better off going a different direction. And this is another one. I treated number 21 originally on this patient. When they came back for 6-month recall, the radiolucency was reducing, it was healing, but now 20 was fractured. And you look at the quality of the restorative treatment here, it just made total sense to extract both of these and put in 2 implants. And look at how nice his crowns fit on the implants. You can't make them fit on teeth very well, but at least some of them fit on the implants. And I've posted this case a few times on TDO chat. I treated this lady probably 5-6 years ago. Treatment considerations aside, if we're gonna, she was there because she had 19 was symptomatic. So there's a long story that goes with this, but the bottom line in this story is if we're gonna treat 19, she didn't want it extracted, she wanted it treated. If we're going to treat 19, are we going to send this patient back to the same restorative dentist afterwards? It's a bad thing, obviously, for a specialty practice to take one patient and refer them to somebody else. It's probably death to a specialty practice if word gets around that you do that. But sometimes you just have to do it, and this was one of those cases. I told her, look, if we're going to go to all the trouble and expense of treating this tooth, I'm going to need to send you to somebody really good because it's going to be really hard to restore this tooth. And it's no knock against your doctor, but there's no point in spending all this time and money that it's going to take care of this tooth unless you're willing to go to somebody really good. And so she said, okay, that's fine, I'll do that. And I said, oh, and by the way, I'd appreciate it if you didn't mention this to your doctor. The funny thing about this guy is I've treated his wife and I've treated his son, and their dentistry doesn't look much better than this. So, and it's not that he's a bad person, he just doesn't get it. So I'm preaching to the choir here this idea about preserving as much of the tooth as you can in the process of doing the endodontic treatment. There's lots of literature to support it, the importance of the ferrule, and I'm not going to go through all of this stuff. These are all things, though, that are important to restorative dentists. So we need to do the endodontics in such a way that we preserve as much of the tooth as we can, and particularly preserve the cervical dentin for the ferrule. And this is all stuff that everybody here probably is very familiar with. We need to do endo in a way that weakens the tooth as little as possible. And if you look, we look at CT images all the time. The idea of coming in towards the incisal edge, makes perfect sense for a variety of reasons. And I show this slide during debates and when I lecture to restorative dentists. I say, which one of these would you want in your mouth, the traditional approach or the more conservative one? And same thing here, relatively little weakening of the tooth in the process. And the restorative dentists, they get this right away. the stepped access, the cotomy stepped access. You know, this is the way we all want to practice. All right. And again, I'm preaching to the choir here the idea of restoring the teeth immediately. For an endodontist that knows what they're doing, this is the best thing for the patient. And that's the main argument that I make as we were trying to get our restorative dentist to let us do some of the restorative, was that the patients prefer it, the literature supports it. It's not a profitable procedure for us, but we do it because we think it's the best thing for the patient. It's hard for them to argue against that. So restore them immediately. It's a quote from Winston: "Nobody benefits if the endo is successful and the tooth fails." The thing is, we make this distinction about, well, the endo was successful, it's not our fault that the tooth had to be extracted. The restorative dentists don't make that distinction. All as they see it is, this is an endodontically treated tooth that failed. So we can't control the biology, but we can control how the initial restorative is done. And that has a big, and there's lots of literature that it's easy to make a case based on the literature. Lots and lots of studies that support it. So in our practice over the years, we've developed it in such a way that the vast majority of almost all the cases we treat, we restore them right away. There's a few exceptions, but almost all of them. So, and we try to do some things to, some little extra things that make us different from the other endodontists in the community. So like in this case, we completed the endo, did the build-up, and rough prepped it. And generally speaking, the worse the restorative dentist is, the more we do for them. Same thing here. So we cut off the bridge, removed the decay, assessed restorability, decided it was restorable, completed the endo, did a build-up, and rough prepped it. And so the restorative dentist just needs to maybe modify it a little bit, put some finish lines on, and it's ready for an impression. And for these two guys that are really bad that we still work with, we have a deal with them where we do the whole crown prep. We charge our patients a little bit more and schedule a little bit of extra time and do the whole crown prep for them. So all they have to do is pack the cord. And this kind of stuff is great when you lecture around the community. I don't say it that way. I don't talk about, you know, the worse the restorative dentist is, the more we do. I get rid of that caption. But I show these cases when I lecture around the community, and nobody else does this kind of stuff. And then on rare occasions, we'll even do this. We'll do the endo, do the build-up, fully prepare the teeth, and pack cord and send them from our office to the restorative dentist's office. So all they have to do is pull the cord and take the impression. We don't do that very often, but on occasion. I'd be interested in Winston's take on this, actually, when you talk about cracked teeth. So we argue all the time on TDO chat about cracked teeth and whether we should treat them and which ones we should treat and so forth. And so early in my career, I treated a lot of them because I was, that's the way I was taught in my residency. Yeah, go, as long as there's not deep probing or movement of the segments, go ahead and treat them and they'll be fine. And so for a period of time there, I had a whole series of these coming back that were failing. This is actually one of Rick D's cases. This one, I show this one just because at 6 months it was healed basically, but then at the 4-year point where we saw him, now there's a big bony defect. It's not a very good implant site, or it's not as good an implant site anymore. This was all of these were cases that were known to be cracked. So anyway, listening to all of you guys a few years ago showing these cases that had pretty long follow-ups where you treated cracked teeth. I did some more of them a few years ago, and now they're coming back. And this is one of them at 1 year. This is one of them at 4 years. So here's another one. So I'm back to really not treating these other than in unusual circumstances. But I'd be interested, you know, Winston, if you can remember, to be interested in your thoughts on that. And I'm talking about teeth with cracks that go down into canals. Now, I'm not talking about cracks that stop short or go under cusps like you see here. You know, those, they just have the same prognosis as any other tooth. And these are the ones that are hard to decide, where there's a crack that goes partway down, like you see here, or like you see here, but doesn't go into a canal. I'm pretty sure these cracks eventually spread down into the canals and cause eventual loss of the tooth, but I don't know. I treat some of these. Hopefully I'll be retired by the time these start coming back. CT imaging, as many things, is helpful sometimes in this decision process. Generally speaking, a lot of the guys that I work with, they just don't want us to treat cracked teeth. They would rather take the teeth out and go to plan B. So when I lecture to sophisticated restorative dentists, I always talk about this multi-visit model that we use most of the time. And they're very much in tune with that. You know, they don't care how you do it as long as you get good results and the patients come back to them without problems. But when I discuss kind of our rationale behind it, they're very supportive of it. Sophisticated restorative dentists, they're used to long drawn-out treatment plans, and they don't care if it takes an extra month or a couple extra months. What they want is when the patient gets back to them, they want it ready to go with no problems. We started out, we did a lot of single visit when we first started out, and you know, we'd occasionally get a call from the doctor, hey, the patient is in here and I'm getting ready to do the crown prep, but the tooth's still bothering them. And so we've pretty much totally eliminated that now with this multi-visit model. Either their symptoms all go away and everything heals and we complete it, or we determine that we can't solve their problem and they go to plan B. So endo doesn't always work. When you look at some of the studies, a certain percentage of the time there's chronic pain and there's other problems. And so we want to identify those patients before we send them back to the restorative dentist. I put this one in just because it's kind of a funny story. This guy's a local physician, and I treated him probably 5 years ago or something like that. And he came in and he said he'd been on the internet and he'd been reading about root canal treatment. And he said he wasn't sure if he wanted to do it. He wanted me to guarantee that the treatment would be successful before we started. So he's a urologist, gastroenterologist. So I asked him if he guarantees all of his treatment to all of his patients, and he said, well, no, but I really want to guarantee if we're going to do this. So I told him the only way I could guarantee was to start treatment, put in calcium hydroxide, see if his symptoms went away, see if the bone heals. And so after 4 months, you could see the bone was clearly healing, and I completed treatment. And there's a 4-year recall on him. This is a case one of my colleagues in San Antonio treated, number 18. Did a nice job, conservative access, nice looking endo, but single visit, and it's had persistent symptoms. Not bad, but persistent symptoms. And he's been back to them, and he adjusted the occlusion and did some other stuff, but it's just never felt quite right. So he came in and he needed 19 treated, and so, you know, I did our multi-visit method, and he was symptom-free when I completed the treatment. And so the benefit to me is that if this patient needs another root canal procedure, or if the doctor refers them, probably they're going to refer them to me rather than to the first guy, even though the first guy did a nice job. And sometimes it helps in that you know when you decide to pull the plug along the way, rather than just completing the treatment and kind of see how it goes, and then later on say, well, you know, this isn't really working. Tell them we're going to start treatment, we'll see how it goes. If things aren't improving, in this case, her palpation tenderness after 3 months of calcium hydroxide hadn't improved, and if anything, the radiolucency looked larger. And so at that point, we pulled the plug and biopsied it, and she had an implant put in. Turned out it was just endodontic infection. I'm really running late here, Gary. I'm sorry. I thought when I went through this before, I got it all done in an hour. I'll try to race through the last part of this. So this You all have seen this case if you've been on TDO chat. This was a lady dentist in San Antonio that didn't want these teeth pulled, wanted retreatment done, and so we used this decision point method that I think Mike Pascal is the first person that I heard about this from. You start treatment, you have certain decision points along the way. If everything's going your way as you get to each decision point, you continue on. And that's how this one was. There was deep probing around the mesiorutive number 31. I figured it was probably cracked, but she wanted me to look inside the tooth, so I did, and it wasn't cracked, so we placed calcium hydroxide. There was a sinus tract that healed along the way, deep probing's reduced, and after about 5 months, I think this last picture on the right is 5 months, clearly the bone was healing. And so we cut the crowns off and finished the endo, cut the crowns off, and did build-ups and rough prepped them. And here she was at 6 months, and here she is at 5 years. She got the third molar extracted. Now, these teeth probably aren't going to last 20 years, I don't think. But this is the treatment that she wanted, and this is how we did it. And with these compromised teeth, we want to know, before they go on and do a bunch of restorative stuff, we want to know that the endo is going to be successful, and that was the rationale behind this. Just as an aside, this lady, before I saw her, I'd never heard of her before. She'd never referred a patient to us. And after we completed the treatment, she's still never referred a patient to us. People ask me sometimes, so how do you charge for these? And we charge like 1.5 times for something like this where we know it's going to be long and drawn out. The thing is that these aren't the most profitable cases, but again, I show these when I lecture around the community. I show cases like this, and they really help build your reputation in the community, because nobody else does this other than us and Cade Roundy. There's lots of good arguments against multiple visit endo, and I'm going to kind of skip through this because we've hashed this over. It's not as profitable and yada, yada, yada. These are the things that referring doctors care about. Just happy patients and that you don't create problems for them. You take care of their problems and you don't create problems. These are things that we care about, but they don't care about. They don't care that we had 2 or 3 years of advanced clinical training, that we've read the endo literature, whether we are or aren't board certified, who we trained under. They don't care about any of those things. They just care about the results that you produce. We tend to be in a rush sometimes, so good restorative dentists don't expect you to rush through things, so don't be in a rush. This is a case that at 1 year looked like it wasn't doing very well, even though it was asymptomatic. But then a patient disappeared, and this last picture is at 5 years. And now it looks pretty well healed. The patient still hasn't gotten a crown on the tooth. But so don't be in a rush to do anything if it doesn't look like it's healing radiographically. It's a case of Rick Davis's. The first 2 slides are in backwards. So it's pre-op, post-op, 1 year, 2 years, 3 years, 4 years. They don't look, there's been not very much healing radiographically. But then the patient came back a few years later and they were completely healed. So don't be in a rush to do things. This is the case I showed you earlier. Don't be in a rush to do the perio. See how much resolution you get from the endo first. And then if the patient still needs a Rudamp, then do the Rudamp then. But in this case, it wasn't necessary. Lucky for the patient, they didn't go back and see the periodontist right away. And then I put in a few cases at the end. These are for you mostly, Winston. Some things that endodontists bring to the table that often aren't considered. And I like showing these when I talk to sophisticated groups of dentists. We're doing more and more of this so-called pre-implant endodontics. We see quite a few kids, and some of them have, are in their teens and they have problems that are going to cause them to have the teeth lost, but we do things to keep the teeth around as long as we can. I've posted this case a number of times over the years as we progress. The reason I show this is that very smart periodontist that we worked with referred this patient. This bone graft was failing and needed to be removed. his plan was he wanted to keep around the molar and the premolar as long as possible to aid him in regrafting this area. And he didn't know if we were going to keep these teeth around or not. But he wanted me to start endo, put calcium hydroxide in the teeth, and then we would make a decision, 4 or 5 months later whether we were going to keep these teeth or not. And so, so that's what we did, started endo on these teeth and put in calcium hydroxide. And knucklehead that I am, I broke a file in the molar. And so I thought, well, for sure that molar is going to be a goner. But ultimately, completed his graft, and he said, no, if you can, just finish, the teeth were asymptomatic, finish the endo, and we're going to keep the teeth for now. And so that's what I did. And at 2 years, this lady still hadn't had anything done, an implant or a bridge put in. And actually, here we are now 5 years later. I just saw this lady the other day. And she still hasn't, she's fine with it the way it is, she still hasn't had anything done. So isn't that smart treatment planning by this periodontist to keep these teeth around, at least initially? Otherwise she'd have a big, huge edentulous space there now. This is another example. This lady has severe wear everywhere, and the plan for her is eventually to get crowns on all of her teeth. But she can't afford it now, and right now this number 9 is a problem. And so our goal here is just to keep this tooth around. It's got resorption, it's got a whole bunch of things, it's got a fracture, a bunch of things going on with it. Well, we want to keep this tooth around and see if we can get the radiolucent area to fill in with bone in the meantime, and eventually she's going to get crowns on all of her teeth. And so here we did conservative endo, and then I just saw her recently again. Now we're at 18 months. She hasn't had anything done, but the bone is healed, basically. I got a little carried away with the calcium hydroxide there. But the bone is healed, and when you talk to implant surgeons, I think to a man they say they'd rather put an implant into native bone as opposed to grafted bone. And so in many cases we can, in an interim period, we can regrow the bone for them. Let me just skip over this since I'm running over my time. This is just a kid. It's eventually going to lose this tooth, and we treated it in such a way that we'll keep it around at least until he's in his 20s or so. Same thing here, incomplete fracture. This kid is 16. We're just trying to keep them around until they're into their 20s, and then the other restorative options are available, good restorative options. This is a 15-year-old with a long syndrome that includes resorbed teeth. Same thing, we're trying to preserve these 2 teeth that have an endodontic problem for this kid into his 20s, so 5 years or so. We did endo on him, we did surgery to kind of clean things up, and so here he is at 18 months. There's not very much root and bone here. I mean, this is a terrible crown to root ratio. But these teeth are stable, and so he's, let's see, do I have another one here? Yeah. So he's 18 now, and these teeth are, reasonably stable, and if he's lucky, and plus the bone is all healed now besides, and if he's lucky, he'll make it into his 20s anyway with these teeth. Here's a more severe example, a trauma case. I saw this kid 2 days after these teeth had been fractured. And he couldn't close his teeth together because they were in the way. And so we repositioned these and stabilized them and did endo on them. And we had to do, normally you don't have to do surgery in this situation, but the number 9 was fractured into many different pieces. And so sinus tract never healed. So we had to go in surgically and take out that root. And I probably didn't need to remove the root end from number 8, but since I was in there surgically already and we had to sedate this kid to do this stuff, I just decided to take it out. And so here he is at 6 months. You can see the bone is healing. It's not very good crown to root ratios here again, but so we're at 18 months now. We've got a little ortho retainer in there, and he's 14 now. We still have a long ways to go, but the longer this kid can do without a flipper in there, the better off he is. And I've followed some ortho patients that had severe resorption like this one. This is a 13-year recall, and look at how short those roots are. So they can do amazingly well with really short roots for a long period of time if they're lucky, if they don't get an elbow in the mouth or something like that. And then just another case, we did surgery. I didn't want to disassemble that number 10. The idea was that at 18 months, they would take that tooth out and place an implant in there. They wanted to do one tooth at a time. Well, 5 years went by and the patient came back, and you can see the last, the CT on the lower right. It's, you know, there's lots of nice native bone there now to put an implant in. I just saw this patient the other day too. They're doing ortho extrusion. Actually, they still haven't proceeded on with the restorative treatment plan. And then some of these resorption cases, most of these heroic resorption cases that we do are on teenage kids. Again, with the idea of just keeping the teeth around. And I've got some of these. This is a 4-year recall. And then this is even a bigger, more extreme one. And this patient's at 5 years now. So this patient's 20 years old now. So, you know, they're getting into the neighborhood where they can do other restorative options predictably besides like a flipper. And who knows, this tooth may last for a long time. This is personally my longest resorption case that I've treated. This one is 16 years treated internally. This isn't going to be an implant case, but I just throw that in there. So, picture of our next president. I'm sorry I ran over. I see I ran about 10 minutes over. Sorry. I'm usually better staying on time.